This conference will now be recorded.
Okay, all right, students, good afternoon. So this class will learn about urinary stone disease. So almost always, if they ask about renal stones or ureter stones, bladder stones, etiology factors mostly remain the same, except bladder. There can be some other infections. Like certain infections. Okay, but for most part etiology remains the stones. Okay, and the stone composition also almost always is the same. uh, Bladder stones differ a little slightly than the kidney stones. We'll deal with each one of these in detail. So urinary stone disease mostly in in the kidneys, in the bladder also. These are the most common type of stones. Calcium oxalate stones, calcium oxalate you will see. Okay, then mixed calcium oxalate and phosphate. Then struoid stones, that is magnesium, ammonium and phosphate. Certain type, they call it triple phosphate. So here you can see phosphate. What is triple phosphate? Magnesium, ammonia and calcium. So if plus phosphate of each one, magnesium phosphate, ammonium phosphate, calcium phosphate. So it is triple phosphate. So, and uric acid and cysteine, these stones you will see in people who are having uric acid, like in gout, and and homocystinuria, like some congenital deformity, metabolic deformity is there. Then there are chances of these stones being higher. Otherwise, as such, you will not see uric acid and cysteine that commonly. So let's go. Causes of the stone disease. Okay, so supersaturation of the urine is key to the stone formation. So that is intermittent supersaturation. The patient gets dehydrated. Then crystal aggregations at usually at anatomical narrowing. So narrow places, mostly in ureters, right from the beginning, where pelviureteric junction and where it enters the bladder, there are certain places where narrow junctions are there, where the stones can get impacted like that. So bacterial infection, you please remember this. It is called, if there is in the center of the stone, if there is bacteria in the center of the stone, if there is bacteria, and round that there is stone formation, this is called, what is it called? Nidus. Nidus. So in the nidus of the stone is the bacteria. So then see, certain matrix is a type of content, so that will lead to stone formation. So these infections, they also contribute, E. coli, Proteus and all these things. So what are inhibitors of the stone formation? These are all. You need not remember all of the this thing, but majority you please remember. So citrate inhibits a stone formation. So we'll come to this. I'll tell you. Citrate means like what? Citrate rich foods. If you take, then stone formation is, chances of stone formation is less. And magnesium, zinc, all these. This Tam Horswolf protein, all of these, they inhibit crystal aggregation. Okay, so what all promotes stone formation? Promoters, it is listed here. Bacterial infection, like first is supersaturation. That is the first that constant intermittent dehydration and all that leads to supersaturation of urine, then stone formation. Then okay, prolonged immobilization, then the calcium is mobilized from the skeletal system, and that lead to increase the serum calcium level and thereby excretion, so stone formation. So uric acid levels and purine, all these in congenital abnormalities. Okay, so these are all the promoters, those are the inhibitors. So these are all the differential diagnosis. Hyperparathyroidism, chronic hyperparathyroidism, I already told you. So it is what? Renal stones, then bony
Abdominal
pain,
groans.
stones, bones, psychic moans, and abdominal groans. So that is renal stones, then increased serum bony pain is there, then peptic ulcer disease is there, then pancreatitis is there, then altered mental status is there. So all these, so that is hyperparathyroidism. So all these other state, vitamin D intoxication, all this cause calcemia and calciuria. So in this there is another, what is this? Milk alkali syndrome. What is that? Milk
Due to
alkali
excess
syndrome. That,
magnesium for antacids.
yeah, the people who are suffering from like SDT, gastric SDT, or some uh, uh, acid disorders or flatulence or something, so they keep drinking alternately, they keep drinking milk and these these antacids like the gelusil and all is commercial. So mostly they are made up of what? Aluminum and magnesium composition. So what happens? Milk, calcium, milk and alkali, so both will rise and that will lead to stone formation. So that is milk alkali syndrome. So these are all the causes where calcemia and hypercalciuria is seen. So malignant, this thing, either malignancy by itself can cause hypercalcemic state, like CA breast. It is not a paraneoplastic syndrome, but the cancer by itself can cause a hypercalcemic state. So these are certain of the examples. So let's come to kidney and ureter stones. So calcium oxalate, phosphate, uric acid and cysteine. Calcium oxalate is most common. Then phosphate, triple phosphate, I told you. 3 types of phosphate: calcium phosphate, aluminum phosphate, and struite stones. Then uric acid and cysteine. Okay. Xanthines, these are uncommon stones. Now that the slide is there, you can make a note of this. Xanthine stones, these are all uncommon stones, little rare. Then matrix is infection by Proteus, radiolucent. So uric acid and cysteine are radiolucent. But please remember one thing, all the stones have some amount of calcium. little bit, however radiolucent they may be. So that will give a clue that there is a stone here. Uncommon stones, again, ephedrine, people who are taking constant cough medicine, so ephedrine stones, and indinavir stones. Indinavir is used to, HIV, one of the drugs for HIV infection. So that can lead to indinavir stone formation. So, and triamterene. See, out of all these, you remember brushite next, stones chemical constituents. So this truite and brushite, you try, if you can remember everything, or most commonly struvite and brushite. So magnesium ammonium hexahydrate, that is struvite stone. So, and brushite, calcium hydrogen phosphate dihydrate. So these are all the chemical constituents. So DD for radiolucent filling defect in on see, don't use the word IVP, intravenous pylography. Nobody is using. Previously they used to call it in IVP, that is when a contrast is given to study kidney, ureter, bladder. Previously it used to be called IVP. Nowadays we are calling it IVU, a contrast like urographene. Urographene is given, and then the contrast is injected, then serial films are taken. So then we'll know initially how it will go to the kidney, um, uh, the calyces, kidney, then ureter, bladder. So finally it's excreted. So the all films are taken. So it is called IVU. Okay. So here radiolucent filling defect. So what are all radiolucent stones? You please note down that uric acid stones, then cysteine stones, matrix, the other this thing, sloughed papilla, blood clots, then transitional cell carcinoma, renal cysts, vascular lesions. More important than this, more important than a radiolucent filling, they will ask, at the renal angle, a radio opaque shadow. Radio opaque shadow means what does it indicate? It is given in Bailey and Love, some 7 to 8 DD for a radio opaque uh, radio opaque shadow in the region of kidneys, means not just renal stones. What else could it be? Artifacts like some tablets that are lying in the colon. Then what else? An ossified cartilage at that this ossified rib, I mean ossified cartilage. Then what else? Artifacts. Then any other infections, So some 6 to 8 diagnoses are there. Most commonly it is renal stone, but all the other things also we should keep in mind. So more than this radiolucent, go through that radio opaque shadow. What are all causing radio opaque shadow? Stones in the appendix, stones in the gallbladder. Gallbladder sometimes can descend downwards, so that also can form a DD. So all of these, first is renal stones, then other DD that could be artifacts, then GB stone, gallbladder stones, then fecaliths in the appendix, then ossification of cartilages. So all these things can form radio opaque shadow. Okay. Now let's come to this. Calcium oxalate stones. Calcium oxalate stones, both in kidney and in bladder also. They have this mulberry shape, like a mulberry fruit, covered with sharp projections. So the even in the bladder, in the kidney also, these projections will lead to hematuria. Okay, very hard and radio opaque. So these stones that one of the most common stones which cause hematuria, this calcium oxalate stones. So phosphate, next is phosphate stones. Triple phosphate, I told you, calcium, magnesium and ammonium phosphate. Here triple phosphate. Smooth stones. So minimum symptoms, dirty white radio opaque shadow. Okay. Calcium phosphate, also called brushite, because they appear like needle under microscope. See, it is these triple phosphate stones, mostly not oxalate, triple phosphate stones that take up the, gradually they begin to enlarge and take up the form of the pelvic calyceal system. So that will give the appearance of the staghorn. Stag is like one of the type of deers, these animals. Deer, stag, stag has a bigger horns. So, and they are it is like a multi-pronged shape. So that will give the shape of the horn of a stag. So staghorn calculus means mostly struvite or triple phosphate. So this is how it look. A calcium phosphate, hyperparathyroidism, so increased calcium, decreased phosphate, renal tubular acidosis, medullary sponge kidney. Okay. So these are the some of the etiological causes for these phosphate stones. Uric acid, I told you, uric acid, do not, unless you suspect some metabolic abnormality, do not think of uric acid and cysteine as primary cause for stone disease. Almost always it is calcium oxalate. So next is struvite or triple phosphate. So after that, any congenital abnormality, then you can think of uric acid stones, and cysteine stones. Hard and smooth, multiple stones, yellow or red, brown, radiolucent. So use ultrasound. There is a rule, but it in generally, like, X-ray. Please remember this. Just X-ray can diagnose 80% of the renal stones and only 20% of gallstones. Whereas reverse it, ultrasound can diagnose 80% of gallstones and 20% of renal stones. So like that. But ultrasound is more, even though it can miss a stone sometimes, the other changes. So proximal to the stone, you can have a hydroureter and hydronephrosis. So all the other changes it can easily pick up. So it is more, previously the rule used to be like that. Kidney stones means 80% can be diagnosed by X-rays, and 20% by ultrasound, like that. So nowadays it's not a hard and fast rule. Okay. Cystine stones, autosomal recessive disorder, common in young girls. Cystinuria. So cystine is not absorbed by tubules. Multiple soft stones, okay, pink or yellow, radio opaque. High fluid intake, cystine stone management. High fluid intake, alkalize the urine, that will dissolve most of the stones, and then D-penicillamine or MPG that is used. See, this alkalinization of urine, anything above pH 7 is what? Alkaline. So I'm above 6, right? Above 6. So and lower it is more acidic. So, but in general, suppose patient is suffering from severe UTI, only then and burning micturition, then it is little intolerable. Maximum you try to hydrate the patient so that there is adequate urine output, and then the burning micturition and all will decrease. So certain people do not uh, this is just a temporary method, this alkalization. Like you give some syrups like citralca. These are commercial names. Okay, you give some syrups which can be taken orally. So intake of the syrups, then gradually urine will become alkaline. But that is just a temporary measure, temporarily only. It cannot be a permanent solution. Urine is meant to be acidic. That is the nature. So, and thereby these microbes are killed. So if you constantly going on alkalizing the urine, then that will alter the normal homeostasis, and there will be other abnormalities. So only when there is UTI, patient is having burning micturations, only then we can alkalize the urine. Okay, other causes like regional ileitis, ileal bypass surgery, obesity, the more chances of reabsorption, and so oxalate stone formation, all these. So in ostomies also, chronic diarrhea with bicarbonate loss, systemic case. We'll come to this when I tell you ileostomies. I will describe more about that. So ileostomies, stomas, any stomas like ileostomies, then chance of uric acid stone disease is there. Okay. So clinically history, is the patient drinking enough, then profession, all this. So renal colic, where is it there constantly? A constant abdominal pain in the lumbar region or the renal angles. Okay, if it is lumbar region, then radiating backwards, radiating to the back. Lumbar region, abdominal pain, almost constant abdominal pain, radiating to the back. That itself is a clue that there is renal stone disease. Whereas if it is radiating loin to groin, then that means it is ureter stone. The stone is somewhere, the stones are somewhere in the ureter, loin to groin. So that is the characteristic. Ureter, there are narrow junctions in the ureter, so there are more chances for the pain to be more sharp and more colicky. So it is one of the ureteric stones or ureteric colic, it is one of the DD for appendicitis. Patient can have, in right iliac fossa pain. It can be left iliac also, and it will be sharp agonizing pain. Patient can vomit, and suddenly it will subside on its own until another attack of colicky pain occurs. So therein lies the difference. And also, appendicitis means usually it will be periumbilical pain which will localize in right iliac fossa. But here it is not like that. Here the pain mostly will be wherever the stone is. So sharp agonizing pain which will stop on its own. That is characteristic, radiating loin to groin. So that is characteristic feature of ureteric colic. So this continue to ask history about all of these, and kidney stone, I told you here clinical features. It's a fixed pain in the loin, whereas ureteric pain, it radiates from loin to groin. Sometimes children will point pain like at the end of micturition there is pain, like they'll point to the urinary meatus, so like that. So, and also hematuria, frank hematuria can be there, or only microscopic hematuria which can be picked up on a urinary dipstick or laboratory. So, and pyuria can pus cells can be there. So these are all the so presentation. I told you abdomen tense and rigid, not rigid as abdomen. Patient will have pain. Rigidity is not like as board like rigidity that is there in case of peritonitis. Here nothing has perforated, so mostly it is pain abdomen only. Fixed lumbar pain which is radiating backside. Okay, fixed lumbar pain, that is mostly renal. Radiating loin to groin is ureteric colic. So these are all the investigations. Ask for all the routine investigations, then urea, creatinine, everything. Then see, in emergency cases, suppose you will take, see, all of you note down X-ray KUB, here it is written, that is kidney ureter bladder, plain X-ray of the abdomen. KUB means kidney ureter bladder, it is showing those regions. So even for plain X-ray of abdomen, KUB view, or next I told you IVU, intravenous, here you have to prepare the patient before taking these X-rays. More than plain X-ray, and also if you are using a contrast study like IVU, intravenous urogram, you have to prepare the patient for 3 days. That means 3 days, twice daily you have to give activated charcoal. Please remember this, they will ask. So charcoal tablets and laxatives you have to give, so that the bowels are cleared. This large bowel, all these bowels are cleared of fecal matter and gas, so that when you look at the X-ray or when you look at the film, there won't be these gas shadows and fecal matter shadows interfering with interfering with our interpretation of the these films. So when you emergency, you cannot prepare, you have to take right there, then and there. So otherwise 3 days preparation is mandatory. That is how you prepare the patient for IVU. Or even if plain X-ray, abdomen, KUB, kidney, ureter, bladder also you will prepare. 3 days prior, twice daily you will give charcoal tablets and laxatives. Okay, then ultrasound. Okay, see IVU. See, IVU is often asked as 4 marks question. So you need to read. That's first thing. Two main contraindications where IVU is not done. One is you check before. Certain, not everybody is can tolerate the contrast. So anaphylactic reaction can occur and patient can die. Deaths have occurred. So please check, or keep all this adrenaline emergency drugs nearby, just in case anaphylaxis occurs. Adrenaline, all these life-saving drugs, atropine, then these diuretics to flush out. So all of these. So absolute contraindications, I'll tell you: contrast allergy and allergy to the contrast. The second one is multiple myeloma. If it is there, you cannot give this contrast. So nowadays this urographin and all very contrast reactions, side effects are very much less. So but that doesn't mean that you can give the dye and not not look for not be out aware of the complications. So contrast allergy, multiple myeloma. So you need not give the skip the IVU. Okay, use ultrasound and other modalities where contrast is not needed to make a diagnosis. Then CT. Okay, then these go through these scans. Students go through these special scans that are recommended: DMSA, DTPA, MAG3, this certain like DMSA, DTPA, certain scans are there to study the anatomy of the kidney. So and the certain scans, MAG3 and all, to study the physiology of the kidney, like that. So these are little more sophisticated scans. So this DMSA, DTPA, MAG3 and few more contrasts are there. So this is okay. Helical CT, that is not okay. Management of urolithiasis, I'll tell you, when the course along the course of ureter, what are the narrow junctions? The ureter will start, pelviureteric junction, number 1, that is a narrow. Then when the vas difference or this this any tube crosses, then
Uterine artery and
yeah, external iliac artery, then 4 to 5 junctions are there. Then gonadal vessels. So when they cross, so all of these, when they're crossing the ureter, there is narrowing. So this is where the stone can get stuck. And finally, just before it enters the bladder. So sometimes there will be sharp colicky pain, and you give IV fluids, the pain is relieved. That means the ureteric stone has slipped into the bladder. Bladder is more spacious, so and it will come out. So for all these, for all of these renal stones, ureteric stones, mostly when there are stones. Now the treatment is extracorporeal shockwave lithotripsy. So you use the lithotripter extra, that is the machine, ESWL, extracorporeal lithotripsy, and this I'll show you the machine here. You can see the machine is there, ultrasonic waves are going, and they will blast the kidney stone. See, you can see the instrument. So the waves will go, but everything is pre-decided. You just cannot, keep the patient and go on giving shock waves. So till the stone fragment. So there is a protocol. So for one session, this much amount of ultrasonic waves, strength this much. So so all of these, and you'll repeat it the next day. It's not like you're going to go on fragment, send the ultrasonic waves till the fragmentation occurs. No, per sitting it is decided. So you'll repeat the session. So this is called energy source. For this is all given in Bailey and Lowe. Just focusing device, coupling device, localization. So all of these, the extracorporeal shockwave lithotripsy. The shock waves are given by lithotripter. Then fragmentation of the stone occurs. Then the fragments will pass through the ureter into the bladder and then down through the urethra. So another way of approaching is percutaneous nephrolithotomy, PCNL. So that is percutaneously, you pass under ultrasonic guidance, you pass an instrument. If the stone is obstructing the flow of urine, so under radiological guidance, ultrasound, or pass a nephrostomy tube into the kidney system and remove the stone. Percutaneous PCNL, percutaneous nephrolithotomy. So that is in emergency settings they do. So it depends, the urologist chooses which method, but mostly extracorporeal shockwave lithotripsy, ESWL. The stone is fragmented and then fragments are retrieved, or it will pass. So two very important steps you need to take when you are doing ESWL. What are those? I will tell you. Okay. When you are contemplating on extracorporeal shockwave lithotripsy to fragment the renal stones, so what you need to do is, number one, I told you the nidus of the stone is bacteria. So when you fragment this, when you break the stone, when it gets fragmented, these bacteria which are inside will get released into, released into the pelvic calcium system, and all this then infection occurs. So you need to give antibiotic and continue. So give antibiotics, that is number one. Under antibiotic guidance only you are going to do this. So antibiotics have to be given. Then next, this ureters, you can see here the diagram, kidney, ureter and bladder. The ureters have to be stented. Stents have to be passed in the ureter, so that the stones will not get blocked. When the stent is there, when you have stented the ureter, what happens? From the pelvic calcium system, through the ureteric stent, they will pass into the bladder. If there is no stent and the ureter is by itself, there are chance that it will get obstructed. So When it is stent is there, you can expect the stones to pass through the stent into the bladder. So stent the ureters. Stenting of the ureters is must. Ureters are stented. Under radiological guidance only you can stent. Okay. So ureters are stented, and under antibiotics have to be given. So antibiotics are given, ureters are stented, then you can do extracorporeal shock wave lithotripsy. Fragment the renal stones or even ureteric stones. So they will come into the bladder, and from bladder, either cystoscopic guidance or they will come out through what Foley's catheter you have put into the bladder, so they will come out. So read about the shock wave lithotripsy. Contraindications, relative contraindication when you cannot do shock wave lithotripsy is, suppose severe colicky pain is there. Patient is already suffering from colicky pain or some renal pain. So now you are not going to subject to more ultrasonic waves. So that will aggravate the pain. Okay. So if there is severe renal colicky pain, then you have to wait till the pain subsides. Some obstruction is there. I told you we cannot have you relieve the obstruction or relieve the obstruction and stent the ureters. Infection is there, gross infection, it has to be treated. After infection is controlled, then we can do the shock wave lithotripsy. Even otherwise, minimal infection or you suspect under the after antibiotics have been given, then only we will fragment the stones, extracorporeal lithotripsy. Okay. Then urea creatinine are not stable, then you have to find maybe once the patient is stable, then, and significant hematuria, you wait till the patient is stable and bleeding has stopped. Continue ongoing hematuria, then you more fragmentation you are doing, then hematuria can get aggravated. So these are relatively absolute contraindications, and absolute contraindication is pregnancy. It is written there. Okay, because there is a uh, patient is having gravid uterus, there is a fetus, so relative contraindications, all of these. Okay, all this coupling device, all of this, read about extracorporeal shock wave lithotripsy. But when you are writing extracorporeal shock wave lithotripsy, you mention that since the stone is being fragmented and bacteria is the nidus, antibiotics, number one, antibiotics should be compulsorily given. Then two, stenting of the ureters, stenting of the ureter should be done. Next. Okay, all these other things you can, history and all, you can go through, lithotripter, how it is arrived. So sometimes they're in the stuck in the ureter, you can pass dormia basket. Dormia basket means it is like an unopened basket. So once it goes around the stone, it encircles, then the basket opens, then you can remove it. It is called dormia basket. So all of these are given. PCNL, see here it is combination of PCNL, percutaneous nephrolithotomy, and ESWL. Okay, so with these two procedures, a dormia basket for ureter stones. So so 90%, greater than 90% with extracorporeal shock wave lithotripsy, you can remove the stones. So open surgery can be avoided. So here, this is like about a few years back. Now there are even more advanced techniques. So nobody is doing open surgeries to remove stones, less than 1% or 2%. So 98%, 99% urinary stone disease, wherever the stones are, kidney, ureter, bladder, can be endoscopically removed with ESWL, that is extracorporeal shock wave lithotripsy, most, and stenting the stones will come out, or percutaneous nephrolithotomy. See, the explanation is this: what happens when you pass the ultrasonic wave? There is no explosion of the stone. Stone does not explode. Implosion means like within it breaks. It does not explode. So that is one of the mechanisms that explains. So see, and sometimes, sometimes these fragments only they when like ureter stones, ureter has not been stented yet. There is some stone in the ureter. So what is meant by push and bang? That means you can use some some device, a catheter or a stent, push the stone back into calyceal system, pelvic calyceal system, fragment it. So otherwise this stone will constantly get obstructed within the ureter. So this is called push and bang. You push it back into the pelvic calyceal system, use extracorporeal shock wave lithotripsy, fragment it, then you can easily remove it through the stented ureters. So this much, if you know, it is more than enough. So when the stones are in bladder stones, so an instrument called lithotripter you can use to fragment the stones, or to crush the stones, an instrument called litholepaxy, LAPAXY. So once the bladder stones, it is easy to remove. Through the urethra you pass a cystoscope, that will cystoscope perurethrally it will go into the bladder. Then you can use any of these instruments to crush the stones and remove them outside. So that litholepaxy is used to crush the bladder stones. Okay. See, all these shock waves per sitting, all this, everything is predetermined for renal stones and all. So it is not like per session we will give only this much amount of shock waves, and the session also will last so long. It is not like a continuous session till the fragmentation occurs. So if it is not fragmented today, fine, continue antibiotics, analgesic, and the next day you try one more. So then we'll fragment the stone and then remove it. See here, these things are called, say in the X-ray, third X-ray, you can see wire-like things. Can you see or not? So these are the stents in the ureter. From the bladder, they are going into the pelvic calyceal system. Students, answer me. Can you see in
Yes,
the
sir.
Yes,
third
sir.
X-ray? Yeah.
Yes, sir.
These stents, as you can see, they are curved at the tip. So these are called J stents. J, like Janaki or Jansi, J. That I'm just telling the letter J. So, or the end is so both sides there is both sides it is curved. This ureteric stent is called double J stent. Double J stent, because on both sides there is, you know, in the both in the pelvic cell system, then and in the bladder it is curved. So double J stents, or they call it, you know, pigtail. No, because the end looks like a tail of a pig, so it's called pigtail. Okay. More than that, the term that is adequately used to describe ureteric stent is J stent or double J stent. Please remember. So you have to stent the ureter. So here you can see all these in the second X-ray and all these gas shadows, all these things should not be there. That means you have not prepared the patient properly. The bowel has to be cleaned off the fecal matter and the gas. So otherwise it will interfere with the interpretation. So again, I'll finish off in another 5 minutes. Okay. To avoid stone formation, take adequate amount of fluid, restrict sodium, restrict oxalate. So how are you, and restrict, avoid high intake of purine food. So what purine food, what oxalate food? Anybody? Anyone? It is there
Amino
in
acids we shouldn't consume.
which one?
Or purine. Amino acids.
No, not like that. Just
Protein
remember
food.
these, you know, these type of tomatoes. Which one? Which food did you say? Tell once again.
It's a protein rich food, I said, sir.
Okay, protein. Okay, okay. That much amount of analysis is not needed. You know, just remember this. It's given in textbook. Tomatoes, strawberries, just simple. These are oxalate rich food. So if you are a known case of renal stone disease, then you avoid tomatoes and strawberries and all these things. And what is recommended here, a diet which is rich in okay, and cut down calcium intake also. Restrict means cut down milk and milk products. You need not totally avoid them, but cut down on taking of you know, whichever will increase the calcium. And increase citrus fruits, like more citrus fruits like oranges and all. But here please remember tamarind. Tamarind is chintakai. Okay. So if you are taking more of that charu made of chintakai, you are less prone to get you know, urinary stone disease. So mostly citrus fruits that is there, but tamarind is known to have good uh, amount of citrate, and then it will inhibit stone formation. So tomatoes and strawberries and other few more vegetables and fruits have been mentioned. So these have to be avoided. So this is how. Okay. And you know, moderate amounts of apple juice. You cut down on apple juice, beer, coffee, and cola. You know, see, plums, raspberries, spinach. So all these almonds, asparagus, these have plums, raspberries, and tomatoes. All these have high amount of oxalate. So you need to cut down on these. High amounts of fresh tea you can take. Okay. Maybe Coca-Cola tea means like a green tea, like that, which has citrate. So finally, I will not cut even for the stone, but leaves it. You know, that means in modern days, modern days, modern days like now in advanced centers and all, nobody is doing surgeries to remove the stones. So mostly, please remember, not even 90, greater than 90% means almost 95, 99% of the time it is removed endoscopically, and we use extracorporeal shock wave lithotripsy. Please remember this. And endoscopically, the stones are removed. Nobody is doing open surgeries. So even for kidney, ureter, and bladder stones, so they can be removed endoscopically. So that's about it. This is a briefly I have told you, because anything you can get as a short note. So how to manage, or ESWL you can get as a short notes, or they might ask urinary stone disease as a essay question. Then you can write about all. I told you types of stones: oxalate, triple phosphate commonly. Then many metabolic disorders are steroid. Then any metabolic disorders are there. Then uric acid and cysteine, like this. And management is extracorporeal shock wave lithotripsy and retrieval of the stones. Okay. Okay. Thank you. We'll meet in the next class. Thanks.